And I'm inviting the chairperson for the next session to be on the podium, Professor Mervet, Professor Neama, and Professor Azza Qatta. And we'll start with Professor Hayam in the first presentation. Professor Hayam.
Okay, Bismillah ar-Rahman ar-Rahim. It's my pleasure to introduce Dr. Hayam al-Damanhouri, who is the current president of the working group of electrophysiology at Ain Shams University. She is doing a lot of work in this situation with the lack of supplies, equipment, devices, but she's doing really an mission impossible. Mission impossible. Dr. Hayam has a long history of education and teaching, and she has a simple way which she inherited from our late Professor Mamdouh Al-Ashri, rahmatullah alayh. We always remember him as simple is easy. Make electrophysiology palatable, make it accepted by young generation, then you will have a whole nation of electrophysiologists. Dr. Hayam.
شكرا دكتورة ميرفت. مش عايزة أقول مامتي، يعني مامتي معنويا وأختي الكبيرة والمنتور بتاعي، وأنا أفخر إن أنا أبقى أعجز تلامذتها. يعني الحقيقة الموضوع بتاع النهاردة is very simple، ومفيش كلام فيه كتير حتى في الليتريتشر، وناقصه يعني full of gaps. فحتى ممكن احنا ناخد افكار لريسيرش جميل من الموضوع ده. هنتكلم على ال AF related dementia. Is it a cause or an association؟ خلينا كده نتخيل سيناريو. A 40-year-old Egyptian gentleman with no cardiac risk factors. At the age of 30, he started to have attacks of paroxysmal AF that were rather frequent, so he complied to his medical treatment, which was propafenone, then amiodarone. However, he continued to experience occasional attacks. BVI was attempted twice with subsequent recurrence. 5 years ago, there was failure to cardiovert him by any mean, so he was kept on rate controlling therapy. He has no relevant family history. His echo was repeatedly normal, apart from gradual progressive left atrial dilatation. Cardiac MRI showed normal both ventricles with no evidence of any infiltrative diseases, as his CHA2DS2-VASc score was 0. He didn't receive oral anticoagulation. A few months ago, his wife started to notice decline in his short-term memory and the impairment of some executive functions, such as inability to reach familiar places during their outing, وابتدى يحط الغسيل في فرن البوتاجاز. فهي ابتدت بقى ايه، يعني ده كان ريد فلاج، وابتدت to seek medical advice. Cardiac reassessment and the neurological evaluation involving brain MR I showed no abnormality. All his labs and oxygen saturations were normal. يبقى احنا هنا قدام patient middle aged ultimately بقى في persistent AF، ما عندوش فاميلي هيستوري، ما عندوش اي ريسك فاكتورز، وابتدى يجي له ديمنشيا. البوزيتيف بوينت الوحيده عنده السلولي بروجريسيف ليفت اتريال انلارجمنت، يعني عنده some sort of atriopathy or atrial myopathy. طيب احنا عرفنا ازاي ان هو عنده ديمنشيا؟ وهل الديمنشيا دي is caused by AF او is this because he didn't receive anticoagulation? Should we have put him on oral anticoagulation? Could repeated timely cerebral imaging predicts cognitive decline in patients with AF? Is there any available interventions to prevent dementia according to imaging results? And should any patient with AF be evaluated for cognitive changes? كل دي أسئلة لازم نسألها لنفسنا، بالذات في patient like this. وكل دي الليتريتشر ما اداش فيها solid evidence عشان نقرر نعمل كده. طيب نعرف الأول إيه هي الديمنشيا. It's an acquired disorder that is characterized by a decline in cognition involving one or more cognitive domains. الليرنينج والميموري واللانجوج والاكسكيوتيف functions والcomplex attention والموتور والسوشيال كوجنيشن. طبعا الاكستريم بتاع الديمنشيا هو الالزهايمر ديزيز. ممكن يبقى فيه dementia وممكن يبقى فيه mild cognitive impairment. This is an intermediate state between normal cognition and dementia, لكن ال overall function بتبقى كويسة وغالبا ال patient أو ال relative مش هيسيك medical advice إلا لما نبتدي نحط الغسيل في الفرن أو المفاتيح في الثلاجة أو something like this. There is debate about the correlation between AF and dementia or cognitive impairment. Whether AF is a direct cause or a contributing factor, or it's just an association because both of them share a common risk factors. However, there is some evidence that dementia, especially the mild form of cognitive decline, is caused by or more common in patients with AF outside the context of stroke. Patient never had a stroke, whether he is on oral anticoagulation or not. In several observational studies, there was a high incidence or higher incidence of dementia or cognition decline in patients with AF. And there is factors favoring this causality, like association is stronger in younger patient. Cognitive impairment, its association with AF is stronger and more evident in younger rather than older patients. And increased risk of dementia with longer time in AF. Patients with permanent AF more than patients with paroxysmal AF. And the temporal relation between the two conditions, usually from the observational studies, the dementia or the cognitive declines begins after beginning of AF. So why AF can cause dementia? Stroke مفهومة. Without stroke, subclinical cerebral infarcts may occur, microbleeds from anticoagulation, brain hypoperfusion. All of this may lead to dementia. Another factor is the inflammation. We know that AF may be associated with inflammation, and inflammation may be accused for the development of AF and dementia. Especially that the CRP and other inflammatory markers is commonly elevated in patients with AF, especially those who have cognitive impairment. وزي أنا ما قلت في البيشنت بتاعنا left atrial cardiomyopathy or atrial isolated atrial cardiomyopathy, maybe it has some reason through inflammation or whatever to cause cognitive impairment. As I said, many studies, most of them are observationals, and some studies, when they were designed, they considered the presence of risk factors, but the authors they didn't follow up the development of new risk factors. So there is growing evidence suggesting a consistent association between atrial fibrillation and cognitive impairment. وده الكلام اللي احنا قلناه. This is another trial, atrial fibrillation, cognition decline and dementia, and there is also an association in a community-based observational studies. Adequate الجديد في البيبر دي ان adequate oral anticoagulation improved management of overall cardiovascular risk profile in individuals with AF, and this is offer the promise of reducing the impact of AF on cognitive decline and dementia. ومن هنا هنبتدي نفكر هل احنا هندي anticoagulation في البيشنتس دي regardless the CHAD VASc score ولا لا. وكان الانسيدنس اوف ديمنشيا وجد ان هي اقل كمان في العيانين اللي بياخدوا دايركت اورال انتي كواجولانتس اكتر من الفيتامين كي انتاجونست. This is another study showing that the overall people with newly diagnosed atrial fibrillation had a 13% higher risk of developing dementia, amplified risk in people whose AF diagnosed was before 65 years of age. There was 65% higher risk. Another study was done by analysis on the ARIC study cohort and showed the same results. And even in patients with Alzheimer, presence of AF was associated with more severe form of cognitive impairment. So, regarding brain imaging, could we have positive data? Yes. Silent brain infarcts, focal atrophy, evidence of small vessel disease, whether by MRI or CT head or advanced neuroimaging modalities. But we don't have a definite recommendation whether to do this imaging at the beginning of AF and to repeat it thereafter, or even do it with any manifestation of dementia. All of this, of course, outside the context of stroke. So who should be imaged and when? We don't know. What are the implications of incidental findings? We do not know till now. What is the role of follow-up imaging? No answer. This collaboration of researchers, they mentioned the gaps of evidence اللي احنا عايزين نملى جزء منها دكتورة ميرفت ممكن تكون projects نعملها. The role of oral anticoagulation in specific subgroups زي low stroke risk, short duration of AF or after successful AF ablation. The effect of rhythm versus rate control strategies in induction in reduction of the prevalence of dementia. This is another gap. Screening for AF in cognitively normal versus impaired patients. Screening for cognitive impairment in patients with AF are debated. Should we screen all patients with AF for cognitive decline, or we should wait till the patient or his surroundings start to complain? So, to conclude, AF patients may show faster decline in cognitive function than those with sinus rhythm, needing more meticulous assessment of mental and cognitive state. Adherence to oral anticoagulation may reduce the risk of cognitive impairment in AF patients, but this risk is still independent from the risk of cerebral stroke. Therefore, paying attention is warranted to other risk factors and comorbidities that may affect cognitive function. Thank you from my lovely kittens.
شكرا بروفيسور هيام.
فين السلايد الأخيرة؟ في سلايد أخيرة. اديني بس آخر سلايد. أيوة اللي فاتت. بعد الثانك يو
شكرا
بس كده عشان we shouldn't forget. مستعدة للأسئلة. تفضل.
It's clear. Everything is clear.
قلت حاجة مهمة. You mentioned very important point. We should look for dementia in AF patients and we should look for AF in dementia patients.
صحيح.
يعني any واحد عنده AF we have to take care of his brain, and any dementia patient we should look at his heart. لان هما الاثنين مرتبطين ببعض.
صحيح. هي الحقيقه الديبيت ده حتى دكتوره ميرفت مش للديمنشيا بس، للناس اللي بيجي لهم الاولد ايج اللي بيجي لهم ستروكس وانت ما ظبطتيش عندهم اي اف، ولما بتعملي هولتر بالكتير بتلاقي
اتريال تاكيكارديا
فريكوينت اتريال اكتوبي. انا كان عندي بيشنت كده الاسبوع اللي فات الحقيقه، لو بيتر موجود هنا انا قلت له اديها انتي كواجيليشن.
انا بدي
الحقيقه
لما بلاقي ستروك فور وومن توايس بيسموها دبل ستروك والهولتر يا دوبك اتريال تاكيكارديا، انا اي جو اجينست ذا جايد لاينز اي جيف هير نوات
ايفن اكتوبي.
ايوه ليه؟ لان العيانين اللي مركبين بيس ميكر وان ذي هاف ريبيتيتيف اتريال ريسبونسز اللي هي النون
الهاي اتريال ابيسودز
later they go into AFib. يعني أنا I saw it on follow up of patients on over years وأكيد أنت
شفتها
شفتيها
كتير.
طبعاً.
انا شفت واحده كانت مدرسه فرنساوي فقدت النطق بعد ستروك، وعملنا الهولتر في ساعتها وطلعت على انتي بليتلتس بس، وبعد شهرين جالها فرانك اتاك اوف اي اف. فالحقيقه انا برضو اجينست الجايد لاينز ومع الكونسيدريشن.
أنا ما بسمعش كلام الجايد لاينز وقولوا لخوزيه مورينو بقى.
انا بدي ممكن دكتور نعيم ودكتور يحيى يقولوا لنا يعني their experience ايه في السعوديه.
So actually, when it comes to the risk of stroke in patient with atrial fibrillation, we really don't know. So the guidelines, as you know, in 2012, I think there was a paradigm shift in the way we think. Before that, we always think which patient with AFib require anticoagulation, but that has changed with the time. Now we consider every patient potentially for anticoagulation unless he is extremely low risk. But the definition of extremely low risk is not supported well by data. What do you mean by extremely? For example, if somebody has a weight of 120 kg, is that considered in the CHA2DS2-VASc score? It doesn't count. If he has dilated left atrium with a lot of scarring, atriopathy, is that part of the CHA2 score? No. So there is many other risk factors in not represented in the CHA2DS2-VASc score, and we still consider these type of people low risk. But in fact, one day, even those with low risk, they will have stroke, or they might present with dementia, multi-infarct dementia after multiple small infarcts. So the clear answer, I basically don't know. Currently, we have to follow the guidelines, but in extreme cases, we see the opposite, that patient comes with stroke or multiple stroke, and the neurologists say, we don't find AFib. So we do Holter after Holter, and some of them we put reveals. A few of them, after we insert reveal, I think we had a collection of 40%. Actually, 5% of them, they had AFib. But the remaining did not have AFib. So is that enough to warrant empiric anticoagulation for anybody who is not supposed to have stroke, but he did? He's not too old, he's not diabetic, but he presented with stroke. Is that enough indication to anticoagulate? The neurologists, they will argue against anticoagulation because anticoagulation itself carries a risk of bleeding.
Yes.
So it's a dilemma, or we manage every case by its.
ما هي لما بيبقى اولد ايج جاله ستروك مفيش اي اف، بس التشاد فاسك سكور بتاعته هاي، فدي البيشنت اللي انا قلت اللي انا حكيت عنها اللي انا اديتها. ما اعرفش بقى مستر ام اللي احنا اتكلمنا عنه ده في ظل الفرانك ديمنشيا دي والاتريال.
So I will answer it in different way. So any patient who comes with stroke, or even the threshold for starting aspirin for a patient is very low by neurologists, by cardiologists, by especially though if they have micro infarct or they have already had stroke. But we still resist starting anticoagulation. Why? Because the risk of bleeding. We know the Averroes trial, I think it's the Averroes called, it showed the risk of bleeding is comparable to aspirin. So why we don't use NOAC instead of especially the Bexabat? Why the Bexabat? They carry the same risk of bleeding,
yes,
but in case of AFib, they provide much more protection.
Yes.
So I think if you look this way, you might decrease your threshold to start anticoagulation.
Okay. Thank you. Any other question?
No, I think if you for the comment, I think we're sharing the same thing. So guidelines does not give you a general coverage for all the patient criterion.
Yes.
So there is a patient that off guidelines we anticoagulate. Artesia trial that just published last month looking into giving oral anticoagulation. That patient never had atrial fibrillation, but they have high atrial rate in the devices, and they saw the much benefit of a risk reduction in term of stroke. So your observation, Dr. Merv, is absolutely correct, that you see high atrial rate in a patient who is at risk for stroke. It's very safe to go with anticoagulation, especially if their bleeding risk is low. But if the bleeding risk is higher, then we have to think about that.
Okay, thank you.
Atriopathy, because this is probably a marker of atriopathy. Is it, we always think of AFib caused stroke by stasis because there is no contraction. This is one factor, but I think more important is the atriopathy. Even absence of AFib will cause stroke.
Yes.
تمام. بسم الله الرحمن الرحيم. طبعا يشرفنا وجود بروفيسور نعيم الشعيبي من المملكة العربية السعودية. بروفيسور نعيم consultant of cardiac electrophysiology, president of Saudi Heart Rhythm Association and the chairman of cardiovascular department King Fahd and Sulaiman Faqih. He will talk about important topic. Persistent atrial fibrillation, other ablation strategies beyond pulmonary vein isolation.
طيب.
اوكي ده عشان نولع الليزر الاحمر وده عشان نجيب النكست سلايد وده باك.
شكرا جزيلا. السلام عليكم ورحمة الله وبركاته. Dear chairman, colleague, thanks for the invitation. I'm here just to present my group. Happy to be here. I think the last time me and Dr. Yahya, we came to this meeting in 2018, and we are happy always to help and support and to attend. And we've learned a lot from all the dedication. The thing that I like to start with things that I don't like. I've heard the comment at the beginning that Egypt, we are a poor country. I think Egypt is not a poor country. Egypt is very rich by the people that they have, by the hospitality, by the knowledge. I think no single country in the Muslim world or the Arabic world have not learned anything from Egypt. So Egypt has a lot of things to say. So, all right. So I've given you the task to talk about persistent atrial fibrillation, anything beyond the pulmonary vein. So as we know, going atrial fibrillation generate more atrial fibrillation. And always, as our interventionist colleague, they said, time is a muscle, and atrial fibrillation is, again, time is atrial fibrillation. So if you look into more persistent AFib, we lose a number of good myocytes. We are losing a lot of fibrin, we get a lot of fibrosis, and we are losing the space between the normal cells. And we translate this into 3D mapping with voltage reduction. We have a zone of a slow conduction, and we have a fractionation electrogram. And this is because of the atriopathy that we know with the atrial fibrillation. So what are we doing if just doing pulmonary vein isolation? I just show you this slide for if we just isolate pulmonary vein, it's better than antiarrhythmic in term reduction of the fibrosis. But still, after 1 year, 2 years, the amount of fibrosis is still there. So pulmonary vein isolation lessen the episodes of atrial fibrosis, but does not stop the process. And if you look for the triggers outside the pulmonary veins, we have a lot of publications. Sometimes even RT is a trigger for atrial fibrillation. Right-sided flutter, SVC, posterior wall, Marshall, atrial appendage. So there is a lot of triggers. The thing that we are not really understand at this time, we should not treat all persistent atrial fibrillation as the same. Persistent atrial fibrillation, it's a group of diseases called persistent atrial fibrillation because every patient has a different characteristic. So I'll show you a couple of evidence. What are we doing right now? And this is the task that has been given. This is the recent publication this year about if you're doing a long waka, let's do a double waka. Is there any benefit? There is no benefit. If you get another lesion beside your good lesion, you're not add anything in terms of reduction of atrial fibrillation. But STAR-AF trial that is published in 2010, this is the first respected trial, look in detail of pulmonary vein isolation alone plus CAFE. Or CAFE alone, when what is the result? It seems doing pulmonary vein isolation with the CAFE lesion, you're gonna get less burden, more freedom of atrial fibrillation over time, especially after the 6 months. The STAR-AF investigator, they get so excited, so they went to STAR-2 trial. And the STAR-2 trial, look how to manage persistent atrial fibrillation. And what they did pulmonary vein isolation, plus line, plus fragmentation, and it seems to be there is no benefit. If you're adding more lines into persistent atrial fibrillation, there is no benefit to add maybe pulmonary vein isolation is enough. But I'm gonna show you a couple of data. I will try to conflict myself. I'm gonna give you something positive and something negative. And this is why we still have a room for improvement of knowledge with the non-pulmonary vein triggers. I'll look at this publication, look at that atrial appendage isolation, do whatever you want, do pulmonary vein, do posterior wall, do the triggers, and then randomize 1-to-1 going with the left atrial appendage or no left atrial appendage. And what they see here after the 6 month, there is a clear separation that if you isolate the appendage, you're gonna get more freedom over time. Not in the first year or 6 months, afterward. And this is the slide show you the benefit of left atrial appendage. And the most important thing, if you look at the lower slide, it is not of a major risk. There is no difference in risk of adding left atrial appendage. So we are gaining some benefit of freedom without getting more risk of the procedure. Then today they mentioned about the Marshall. So with stepwise Marshall, what they're trying to do, go through the coronary sinus, get the connection between the distal coronary sinus and left atrial appendage, and inject alcohol and to see whether we have more of freedom, plus the pulmonary vein, plus the posterior wall. And it seems if with the first procedure, the success rate around 80%. If you did another procedure, we'll increase this to 90%. So Vein of Marshall maybe has a role. So did we stop there? No. Some group, they went to the other one. Let's go to the Bachman bundle in the septum. By the way, Bachman is the fastest conduction system in the heart. Plus, it is the slowest conduction system in the heart. It's a lot of fibrosis, a lot of elements that can get to speed and getting slow, and that could be zone of abnormal electrical activities. And going with the Bachman bundles, the researcher in this group, they think if you ablate Bachman, then you'll get more freedom. So now we hear Vein of Marshall, Bachman, and people still try to figure out what are we doing. This is why, because persistent is not a one disease. What about posterior wall? There's a lot of heterogeneity. Small publication look into posterior wall has a role. Other publication, it seems a very neutral with the pulmonary vein isolation. And the Kabbalah that is being today presented with Dr. Mervet, it seems doing another line, a posterior line isolation, it showed no much of a difference of a pulmonary vein isolation. So it seems to be posterior wall is not a big story with the atrial fibrillation persistent. It could have a room in some patients, but overall is not helpful. So what is new? Now we are moving into body surface mapping. Get patient during atrial fibrillation, give them a vest, put them the CT scan plus MRI, try to see where is those original of atrial fibrillation, where is the most rotors. And hopefully with this, and this is an important slide what it's showing, atrial fibrillation, it's changed by weeks. 2 weeks, you'll get 2 rotors. After 3-4 weeks, you're gonna get more 3-4 rotors. So this is why the time is very important. If the patient wants to go for atrial fibrillation, you have to do it as soon as possible and not to wait. And this is an example with the body surface. If you ablate, you're changing the electrogram from more fractionation into more of organized pattern. And that could help stabilization of the atrium. And this slide shows you the most efficacy of going for the driver, that if we are able to look into the driver and ablate, we are going to see benefit of reducing atrial fibrillation in the future. And this is a very important concept. If you look at the slide, this is all patients with atrial fibrillation persistent. But first patient has a focal rotors, the other one has a localized rotational activation, and the third patient, they had localized irregular activation. This is why persistent atrial fibrillation is not one disease. Every patient has his own criteria and has his own shape. Stable, this is another interesting, doing atrial fibrillation ablation during AFib or during sinus rhythm, does it matter? So look into this data. If you are converting your patient into sinus rhythm and doing of substrate looking for the lesion during sinus rhythm, maybe will give you more freedom rather than ablating the fractionation during atrial fibrillation. So this is another thing that we should think on mind. Other study looking into the ERASE-AF trial. ERASE-AF trying pulmonary vein against pulmonary vein plus low voltage criterion based on a CARTOMAP. And it seems if you have a good mapping for the low voltage ablation plus the pulmonary veins, you get more freedom than pulmonary vein. So maybe pulmonary vein is not all the story. Some patient will get improved with other thing. So our job to know what is the other thing. Is it the Buckman? Is it pulmonary vein as just posterior wall? Is it something that we have just to go with the fractionation or the low voltage? What is the people in the Milan decide to do? They will do a pulmonary vein plus doing empirical mitral line for everyone and see. And this is why everyone is trying to help, because it seems to be in the persistent of atrial fibrillation, we're still not getting there with the success. And what they found, after you need 2 years of a separation of a curve. After 2 years, if your patient has anterior mitral line, they will get less risk of AFib after 2 years of the procedure. Ganglion plexus, in terms of paroxysmal, maybe it will improve, but during persistent, it has no role if you're ablating the ganglion plexus. This is another now trial that we're gonna learn from that, COAST-AF trial. This is most recent trial that has not published, looking into pulmonary vein. Again, it's pulmonary vein with the low voltage ablation. And hopefully with that, we will get some knowledge. They are almost closing the study and hopefully will get published within 6 months or so. The other thing is coming up, STAR-AF3 trial. And this was the STAR-3. They go with the wide pulmonary vein plus pulmonary vein with the drivers or pulmonary vein isolation posterior wall. And this is, again, it will be published this year. So persistent AF, less is more. Actually, no, it's not really. We can see some people that they get benefit from something else. But it all depends what exactly we do. Why we do not have systematic approach with the pulmonary vein isolation. So we're going to learn from STAR-AF trial 3 and COAST-AF trial. So what is very interesting, maybe we need to do EP study in patient with atrial fibrillation, identifying people with very zone of conduction, ablating all the zone of conduction, low slow zone conduction, maybe that's would reduce. This is something that what we call it unmasked functional atrial remodeling. Let's go back. Go back. Sorry, I'll just go back to the last slide. I think this is jumped. Right. What are we maybe going with the AFib? Personalized medicine. Maybe in the future, rather than give your patient statin, you don't know what's a statin, maybe there is a blood test, they will say, if you give atorvastatin, maybe better than beta-vastatin for this patient. Atrial fibrillation, maybe we're going to all those knowledge. We know that some people, they understand, they get benefit from posterior wall, left atrial appendage, and some people they know. Maybe by including the AI in the future, maybe that will help us in terms of getting personalized medicine rather than treating all persistent atrial fibrillation altogether. And this is just one of the studies that looking into AI in terms of understanding the ECG, the study of during 3D mapping, and let's help with the programming software to tell you where to ablate and when to ablate. And with this, they compare, and this is very important, the result of pulmonary vein isolation in a busy center is not like pulmonary vein isolation is not in a busy center. With going in the artificial intelligence, they might tell you, you have to isolate pulmonary vein, isolate posterior wall, isolate appendage, and with this, it looks into more expert legend group against non-expert group, and it seems to be this is the only study that's showing that 2 centers that they have a good result, but both of them, they have to give one knowledge where to ablate. So how to ablate? It's very, now we have learned, we're gonna learn with the new future of a new study that we're gonna get. Pulmonary vein isolation, still the cornerstone of atrial fibrillation. Non-BV triggers, it's useful, but we have to know for whom. Is it for not everyone? We know that the septum, posterior wall, SVCs has a rule, and we're still waiting for the large clinical trial. With this, I will say thank you. If you can put the slide, please, the last slide, if you don't mind. This is just example. I will answer it tomorrow, Dr. Mervet. This is my university, King Abdulaziz University. And this is the biggest fountain in the world in Jeddah, my lovely city, Jeddah. So my question to your fellow, to let me know what is the story of this fountain. It has a good connection between Egypt and Saudi.
مين مثقف هنا؟ يا شباب الزمالة، السؤال باللغة العربية.
Not for Yahya.
ها؟
Because
إيه
Yahya is
العلاقة
Egyptian
بين
more than Egyptian. So
اللي في جدة
Jeddah.
ومصر؟ الأهرامات. طول البرج، طول الأهرامات.
So this fountain started in 1980, and they use it's around 3,000 feet long, and they use the machine that it was used in the world of Egypt 1973 in October. Yes.
سقفة جدعان بقى.
فكان
السعودية بتحييكوا اهو.
فهذا كان هدية من الملك
سلام
فهد
كبير
للحرب،
للسعودية يا
وبعدين
جدعان.
أخذناها عملنا فيها كده. فهذا استخدموها في الحرب، وبعدين أخذتها السعودية عملت فيها الفاونتين. Just to connection, yeah. I'm happy to take questions. No, it's traditional. تفضل. Exactly. I'm confused.
What shall I do to my next patient who has persistent AFib?
So as of now, pulmonary vein isolation is enough. If you said that I'm confused, when I start my presentation, I'll say I am going to conflict myself. I'm going to say something positive and something negative. And what we need to know for sure that that persistent atrial fibrillation, it is not one disease. I think the time will tell how to justify patient with, as like patient with diabetes. Diabetes is not a single disease that we use one approach of medication. Same for persistent AFib. Some people, they will go for posterior wall, some people they get, but we have to know what is the approach. I don't think so we're gonna find a unified way to treat all patients with the persistent AFib. تفضل.
Thank you. Joseph Kutzner in Czech has the opinion to do pulmonary vein isolation only for the first time. If there is recurrence, then you can add extra lines, posterior wall.
Yes, correct. So as I mentioned, it seems to be the approach, it's linked to names. This doctor do this doctor do that, but all electrophysiologists, they ablate slow pathway for AVNRT because we understand the disease. All the electrophysiologists, they ablate the CTI for typical dependent flutter because we understand the disease. But for persistent atrial fibrillation, if you go to the different cities, different lab in the same country, everyone does his own thing. This is why we have gap of knowledge. This is, if his approach is okay, but there is other people that they do from the beginning. Bachman bundle? I've never done it. But I told you just this is why we have conflicting data about what to do with the persistent atrial fibrillation. Exactly. Sure.
I have a question, Dr. Naim. What's your personal experience to ablate non-BV triggers during redo cases of AF ablation? What's your what non-BV trigger you ablated?
Non-BVs, you mean?
Non-BV trigger.
All right. So it's really depends on the history first. If the patient has persistent, mild to moderate left atrial dilatation, we know this is not a paroxysmal atrial fibrillation only. So what I do in my lab, I'm preparing myself to go with non-pulmonary vein trigger. So what I will do, I give isoprel. So with the isoprel, I try to put a catheter in the SVC, one catheter in the posterior wall, and one catheter to map the appendage. So it really depends on if I move the patient with a lot of atrial activities and those non-pulmonary vein trigger. But all my patient has to be in sinus rhythm at the beginning. So I cardiovert first, I do a voltage map, and then I try to use the isoprel to see where those triggers are coming from. If I find that I'm convinced that there is a non-pulmonary vein triggers, I try to ablate it. And now this is why I think with this approach he's going to die. If we are getting with the low voltage and we have defined what is the low voltage, maybe everyone we're going to go with the low voltage plus pulmonary vein.
Any questions from the floor? Thank you, Dr. Naim. Thank you for the nice presentation. So our last speaker in the session is Dr. Khalid Shaheen. He will talk about screening for atrial fibrillation, the role of smart technology, the pros and cons. I think Dr. Khalid is with us online, or?
Assalamu alaikum.
Alaikum assalam, Dr. Khalid.
Good evening, Mr. Chairman, and good evening, everybody. أنا بعتذر والله إني مش معاكم، بس أنا لسه متبلغ بالمحاضرة دي الصبح النهاردة، فإن شاء الله يعني تكون كويسة إن شاء الله المحاضرة يعني. Next, please. Atrial fibrillation is the most common and prevalent form of cardiac arrhythmia. It is widely associated with varied consequences from impairment of quality of life to substantial complications such as heart failure, vascular dementia, stroke, enhanced risk of thromboembolic events, and depression. It has been reported that about 1/3 of the total AF population is asymptomatic silent AF. Hence, awareness and early detection of AF is important. So this significant morbidity and mortality make sense for screening of AFib and prevent these long-term consequences. Next, please. How to screen for AFib? People over 65 years of age, people at high cardiovascular risk, people with predisposing conditions such as hypertension, heart failure, coronary artery disease, obesity, diabetes, chronic kidney disease, and obstructive sleep apnea. Next, please. Why screening for AFib? For people with undiagnosed AF, ischemic stroke may be the first clinical manifestation. When used appropriately, oral anticoagulation is estimated to reduce stroke risk for people with AF. So, if it were possible to detect those who had asymptomatic AF earlier, it may be possible to prevent some of these strokes by offering anticoagulation. So, screening is suggested as one strategy to increase AF detection rates and start anticoagulation. Ambulatory monitoring options for AF, consumer wearables such as Apple Watch and Fitbit. It's both widely available and relatively inexpensive, high patient compliance, but rhythm verification as the algorithms in these devices alert the patients for irregular heart rhythms such as atrial premature beats and BVCs, which may be counted as AFib in these algorithms. Other ambulatory monitoring options for AFib is consumer ECG devices such as Cardia, Omron. It's widely available, but its cons rhythm verification, they suffer from the same potential problems with rhythm verification in falsely diagnosing AFib in the presence of irregular rhythm of different reasons. But they can monitor for 30-second interval. The patients may feel palpitation and then put their fingers the device to generate a rhythm strip which can be verified by the physician. Other options are patch monitors, such as ZioPatch, high rhythm fidelity, but it's expensive, and they can monitor days to weeks. Next, please. And finally, those implanted devices made by major device companies such as Medtronic, Boston Scientific, and Biotronic. Next. How much AF is required to be treated with anticoagulation? This is a difficult question, but to answer this question, we have to revise two studies. First one is a CERT trial study. This study evaluates whether subclinical episodes of rapid atrial rate detected by implanted devices were associated with an increased risk of ischemic stroke in patients who didn't have other evidence of atrial fibrillation. About 2,580 patients were enrolled. Inclusion criteria was 65 years of age or older, with hypertension and no history of atrial fibrillation, in whom a pacemaker or defibrillator had recently been implanted. The patients were monitored for 3 months to detect subclinical atrial tachyarrhythmias. About 10% of those patients had episodes of atrial rate more than 190 beats per minute for more than 6 minutes, and followed them for a mean of 2.5 years for the primary outcome of ischemic stroke or systemic embolization. They found that this group had an increased risk of developing AF 5 times higher than those patients who didn't have atrial arrhythmia detected, and the risk of stroke was 2.5 times higher than those patients who didn't have atrial arrhythmia detected. The conclusion of this study was subclinical atrial tachyarrhythmias without clinical atrial fibrillation occurred frequently in patients with pacemakers and were associated with a significantly increased risk of ischemic stroke or systemic embolization. The second study, which is a recent study, is Apple Heart Study. Through Apple Heart Study, Stanford medicine researchers show wearable technology can safely help detect atrial fibrillation. About 400,000 participants enrolled in 8 months. The Apple Heart Study is the largest virtual study to date. The study was launched through a research sponsorship by Apple company to determine whether software on the Apple Watch could use data from the watch's heart rate pulse sensor to identify atrial fibrillation. Of those who received a notification and were monitored by the ECG patch about 2 weeks later, 34% were found to have atrial fibrillation. And the comparison between irregular pulse detection on Apple Watch and simultaneous ECG patch recordings showed the pulse detection algorithms in Apple Watch has an 84% positive predictive value. During the ECG patch monitoring, participants' Apple Watches continued to monitor pulse irregularities. If a participant had an irregular pulse detected, 84% of the time this was confirmed to be atrial fibrillation on the simultaneous ECG patch. So this demonstrates that the algorithm in the Apple Watch can successfully identify atrial fibrillation. The Apple Heart Study application intermittently checked the heart rate pulse sensor for measurements of an irregular pulse. If it detected an irregular pulse, the participant received a notification and was asked to schedule a telehealth consultation with a doctor involved in the study. Participants were then sent ECG patches from biotelemetry, which records the electrical rhythm of their hearts for up to a week. After AFib has been diagnosed, monitoring is useful to monitor treatment efficacy and AF burden. So wearable and single-lead ECG devices can be helpful to monitor for AF recurrence. Take-home message: the ability to monitor and screen for AF is rapidly expanding. long-term monitoring has a high rate of AF diagnosis. Wearable and single-lead ECG devices allow patients to capture rhythm disturbances and aid in the long-term management of AFib. Seconds, population-level screening could lead to significant number of false positive results, unnecessary additional investigations, and health anxiety around the implication of their diagnosis. Thank you.
Do you have any questions for the screening?
حضرتك في ظل وجود ان انا دلوقتي بعمل سكريننج فور اي اف عشان تو بريفنت ستروك او كده يعني، فلو انا اوريدي عندي العيان عنده اترال فايبريليشن، المفروض ان احنا العيانين دول نديهم بصرف النظر ان احنا ما عندناش حاجه دلوقتي اسمها لون اي اف، لان الاي اف بقى ليها باثوفيسيولوجي غير الاول.
تمام.
احنا كان عندنا محاضره من شويه كنا بنتكلم في قصه ان العيان اللي هو الشات فاسك بتاعه دونت ميت ذا كرايتيريا ان انا اديله انتي كواجوليشن، فعلى كلام حضرتك ان احنا كده المفروض انه مجرد وجود الاترال فايبريليشن هيبقى انتي كواجوليتد بصرف النظر.
هو زي ما حضرتك شفت في الاثنين ستادي اللي انا الاسيرت ترايل والابل واتش ستادي، ان في حوالي 34% من الناس او من العيانين كان عندهم اترال فايبريليشن ديتكتد بالديفايسز، وانس ان الايفيب ديتكتد ده كان كاري ذا ريسك اوف complications such as stroke. ف I think once in الايفيب detected by such devices or such or monitored by this smart technology, I think we should start anticoagulation.
شكرا.
هو بس عشان clarify something، يعني هو احنا بنانتي كواجيليت according to the Shad's Vask score، مالناش دعوه بالبريزنس يعني of other things، يعني قصدي الاتريال فيبريليشن بير سي احنا في some patients
انا طبعا دكتور هيثم طبعا بناخد يعني الشات فاسك سكور لازم طبعا يعني بناخده في الحسبان طبعا، يعني انا ما اقولش اللون ايه فيب فقط.
يعني قصدي في individuals with young individuals من غير شات فاسك سكورز.
لا لازم لا احنا الاستادي كانت في اولد بيبول، والعيانين كان عندهم لو الانكلوجن كرايتيريا رجعناها هنلاقي ان العيانين دول كان عندهم هايبرتنشن، يعني هياخدوا واحد في الشات فاسك سكور، فالشات فاسك سكور should be included طبعا.
هو according to the شات فاسك زي ما دكتور خالد بيقول، احنا الاسيرت كانت يعني if they have atrial fibrillation for 6 minutes this might increase the risk of stroke in the patients candidate for anticoagulation. عشان كده نديهم anticoagulation. ده بيتكلم على الناس اللي عندهم asymptomatic atrial fibrillation، واحنا بنحاول نبريدكت مور في الاسيرت ترايل لوب ريجوردر 6 minutes atrial fibrillation. This is indication for anticoagulation if the patients with Shad's Vask يعني بيخليه ياخد anticoagulation anyways، مش لون AF، يعني مش عيان مش indicated.
وهم دكتور هيثم هو كان في الانكلوجن كرايتيريا بتاعتها انهم 65 years of age or older وهايبرتنشن،
يعني كده السكور بتاعهم 2 اساسا، يعني هم كده محتاجين anticoagulation.
تمام. Any question?
Other questions? Other questions from the floor? Thank you, Khalid.
شكرا جزيلا.
شكرا. So we conclude this session.